Here at Atos, we're dedicated to helping improve the quality of life for laryngectomy patients. Many of us are aware of the positive impact heat and moisture exchanges have on pulmonary health and voice rehabilitation after a total laryngectomy. Adherence to HME use and efficiency of tracheoesophageal voice production can be compromised by medical adhesive-related skin injuries and peristomal skin complications. In order to facilitate assessment and management of peristomal skin conditions, Atos UK have developed a tool to optimize in-clinic evaluation and monitoring of peristomal skin disorders. This tool has been developed by our head and neck nurse specialists based on our experience supporting laryngectomy patients, our expertise in peristomal skin conditions, and findings from the Atos Medical White Paper. The aim is to help you as laryngectomy healthcare professionals make a uniform assessment of peristomal skin conditions, as well as help improve monitoring and optimize communication between professionals. In this video, we will briefly look at how the laryngectomy skin assessment and management tool can be used in practice. Here we have the complete laryngectomy skin assessment and management tool, which is a practical guidance for categorizing peristomal skin disorders in total laryngectomy patients according to the cause, so that we can initiate appropriate care. Within the tool, you will find that there are 4 main skin health conditions that we encounter in practice. Each skin health condition is accompanied by a definition as well as an image. Do keep in mind that these images are just examples, and presentation can vary due to factors such as age, general skin condition, as well as ethnicity. After identifying by definition which of the 4 conditions would be what your patient is likely presenting with, you would then move down to complete a full assessment. Let's look at mechanical skin stripping, which is defined as a skin condition where there has been mechanical removal or stripping of the protective top layer of the skin. We then move to our assessment stage, where we would ask ourselves if the skin looks red and shiny, remembering that redness can look different in different skin tones. The tool also guides us with what to expect, as it states that in mechanical skin stripping, the skin can either be dry or it can be moist due to exudate, and in severe cases, you may find that bleeding from the stripping trauma is present. The next stage would be looking at the care guidance, how to manage our patient's skin health concerns. Where our patient is using an adhesive or base plate, we would assess their application and removal technique. We would need to establish whether our patient is using a barrier product, which is a key element when using adhesives, as this protects the skin in the prepping phase. A key aspect in mechanical skin stripping is establishing whether our patient is using an adhesive remover efficiently to break down the glue before removing the adhesive or the base plate. Also, within the care guidance, we would identify how frequently our patient is changing the base plates or the adhesives. Wherever frequency is more than usual, we would then further review if the adhesive shape that the patient is using is appropriate, because ill-fitting adhesives or base plates will likely blow off and not adhere effectively, leading to constant removal, ergo mechanical skin stripping. And last but certainly not least, as guided by the tool, adhesive types matter. Therefore, reviewing appropriateness of acrylic, hydrocolloid, or hydrogel adhesives in each individual patient is part of successful skin health management. Next, let's move on to the maceration and moisture heading. Moisture-associated skin damage is caused by prolonged exposure to moisture, for example, mucus, wound discharge, or sweat sitting under the adhesive. When the skin is exposed to high levels of moisture, it will become soft, pale, swollen, and wrinkled, like our fingertips after a long bath. When assessing the macerated skin, the first step is to establish if the skin damage is mild, moderate, or severe. Mild skin damage will be red in appearance, but there will be no areas of broken skin. You will notice moisture in the peristomal skin area. Care guidance will involve using a pH-neutral cleanser to clean the skin. Pat the skin dry. Don't rub or wipe the skin, as the skin surface will be very fragile. Apply a barrier film under the adhesive to protect the skin from further moisture damage. Review your patient's skin care and adhesive routine to ensure they are properly protecting the skin and applying the adhesive with a complete seal to prevent mucus from getting under the adhesive. It is also important to review your patient's secretion management if mucus is the cause of the maceration. Are they wearing an HME 24 hours a day? Are they using regular nebulizers? Do they need mucolytics, etc.? Moderate skin damage will be more reddened with presence of broken skin that will be less than 50% of the skin around the stoma. Exudate or weeping may be present. Consider a hydrocolloid adhesive where there is moderate maceration, which will absorb any moisture under the adhesive. If this does not improve the skin condition, consider a short break from the adhesive, swapping for a Larry tube or button to house the HME. And finally, severe skin damage due to maceration would still be reddened, with greater than 50% of the skin around the stoma being broken, with weeping present. In this situation, it is important that you consult your local policy and consider a referral to specialist services such as tissue viability. Maceration may develop or coexist with a fungal infection and can be diagnosed by swabbing the area and getting it assessed by your local infection control team. Fungal infection is caused by fungal yeast growth, often in a warm and moist environment. The skin may be discolored, warm to the touch, with superficial skin loss or dry, scaly skin. In this situation, it is important not to apply a barrier film. It may be appropriate for an antimicrobial cream to be prescribed, and this would be a time to swap to a tube or button rather than an adhesive while you wait for the skin to heal, as the cream will prevent adhesion. The third skin condition column is allergic or irritant contact dermatitis. Allergic contact dermatitis is an immune system response to damage of the outermost skin layer. Irritant contact dermatitis is an inflammatory response to damage of the outermost skin layer. A defined border where the adhesive has been sitting suggests irritant dermatitis. A non-defined border suggests allergic dermatitis. There may be blisters, edema, redness, and/or excoriation. Look at whether the reaction is localized or systemic. Is it starting to spread beyond the peristomal area would be a question to consider. A common theme now: assess the patient's adhesive care routine, ensure they're using a pH-neutral cleanser, skin barrier, and an adhesive remover. Have a discussion with your patient to determine if there has been a change in products used that might have triggered the reaction. Do they have any known or other allergies? Has a patch test been carried out to identify any unknown allergies? Discontinue any products containing allergenic materials. Consider a dermatology referral. with potential prescription of antihistamine according to local policy. Consider a break from adhesives to allow the skin to heal, and swap to a Larry button or tube to ensure HME compliance. The final column covers radiation dermatitis, which is a common side effect during radiotherapy. If the skin is at baseline or intact, continue normal skincare and include daily moisturization. If there is mild redness, itching, and skin tightness, daily skincare will need to be more gentle. Consider a steroid cream to ease itching. A moisturizing emollient cream is essential. If the skin is starting to show obvious erythema, sore to touch skin, plus or minus dry desquamation, itching and dryness, use emollient creams for the cleansing routine. Focus on easing itching to reduce soreness. Aim to encourage moisturizing as needed. If moist desquamation with exudate is present, use warm water for gentle skincare cleansing. Use an impregnated, non-medicated dressing. Leave exudate on skin if not excessive, as this will help desensitize nerve endings. Gently pat skin at cleansing stage. Encourage regular analgesia as prescribed. If there is ulceration, bleeding, or necrosis, seek guidance from tissue viability nurses or your clinical nurse specialist from the oncology department or the radiology team. Thank you for listening. Please remember that these are general recommendations for care, and referring back to your local guidelines and policies is vital. Our field nurses, as well as the Best Start nurses and the clinical education team, are available should you need our support, so please do not hesitate to reach out. Take care.